Good morning. The 21st Manahan Lectures in Rheumatology is now streaming from the University of Philippines. I am Dr. Paulo Lorenzo of the Division of Rheumatology, UPPH, moderating this session. Please post your questions at the Q&A box, and we will address them during the open forum. You will receive your certificate of attendance a week after you submit the evaluation form and post-test. The link will be posted later. This fourth year doing the LML online, and today will be the second of our webinar series for this year. The LMLR aims to teach rheumatology to healthcare professionals, an advocacy initiated by Dr. Lourdes Manahan, the first Filipino rheumatologist. This year's theme is Life to the Max. We wish to emphasize a holistic understanding of our patients and their diseases, as well as strategies through which we can make our patients' lives better. LMLR is instead of WHO Sustainable Development Goal number 3 on health and wellness and well-being, and Sustainable Development Goal 4 on quality education. The Division of Rheumatology is happy to announce book publications, the Atlas of Rheumatic Diseases Philippines, and the Physician's Guide to Tele-Rheumatology. These contacts for those who wish to purchase copies. Our lecture today will focus on how we diagnose and patients with gout, apply strategies to improve the control of gout in our community. We are deeply honored to have two distinguished speakers, both graduates of the UP College of Medicine and Internal Medicine Residency Philippines. Our first speaker is Dr. Sidney Erwin Manahan. By the way, no relation to Dr. Lourdes Manahan, but they share the same passion in rheumatology. Dr. Manahan completed rheumatology fellowship at the UP Philippine General Hospital. He is the training officer of the section of rheumatology in East Avenue Medical Center. He is also the secretary of the Board of Trustees of the Philippine Rheumatology Association and the chairman of its Committee on Membership and Credentials. Our second esteemed speaker is Dr. Diana Tamondong-Lachica. She is an associate professor of the College of Medicine and consultant of the Division Hospital. She of patient as overall coordinator of the Department of Medicine Quality Improvement and head of the program for healthcare quality and patient safety of the UP College of Medicine. She is the editor-in-chief of the Journal of the Association of Philippine Medical Colleges and served as project leader of the Philippine Guidelines on Periodic Health Examination PHEX3 Lifestyle Advice. Ladies and gentlemen, let us welcome Doctors Manahan and Lachica as they share their expertise in today's lecture. Thank you.
Good morning. I would like to thank the Division of Rheumatology and the Department of Medicine PGH for this opportunity to be part of the Dr. Lourdes Manahan Lectures in Rheumatology. I also congratulate the division for sustaining this initiative over the last 20 years. I have been invited to discuss the diagnosis and treatment of gout and briefly describe how we manage associated comorbid conditions. These are my disclosures. Gout is the most common inflammatory arthritis worldwide. It results from chronic hyperuricemia, leading to the deposition of urate crystals in joints, soft tissues, and the kidneys. Gout has long been identified as a metabolic condition that, when unabated, results in significant disability. Recently, authors have referred to gout as an autoinflammatory disease after we have better understanding about the role of inflammasomes and interleukin-1 in pathogenesis. Also, genome-wide studies have identified at least 13 alleles involved in the regulation of inflammation to be shared by gout with other autoinflammatory conditions. This map illustrates the prevalence of gout across different countries. Developed countries in North America, Europe, and Asia have the highest disease prevalence. There are still continents wherein we know little about gout epidemiology, like in South America, Africa, and Antarctica. It would appear from this map that the Philippines has a low disease prevalence, but reference in this paper was the 1997 cohort study in the urban setting. The 2008 National Nutrition Health Survey estimated gout to be present in 1.6% of Filipinos. This puts our disease burden at par with those of developed countries. Over the last 3 decades, the world population grew by 40%. During the same time, gout prevalence doubled. It has been more than a decade since the first internationally accepted practice guidelines on gout were published. But retrieve any recent article on gout and you will come across a statement that gout care remains suboptimal. Is this true? Before we address that, let's review how we manage a disease. When faced with a rheumatic condition, our first instinct is to look for criteria to help us diagnose. We must remember, though, that the 2015 ACR-EULAR gout classification criteria was developed primarily for research. It is intended to help investigators recruit a homogeneous patient population in gout clinical trials. Nevertheless, the criteria is instructive as it identifies features that differentiate gout from other inflammatory arthritis. How then should we diagnose gout? The EULAR strongly recommends the identification of monosodium urate crystals in fluid obtained from joints in bursa or aspirates from suspected tofus. This is done via polarizing microscopy. The image we have here is from the archives of East Avenue Medical Center section of rheumatology, showing the negatively birefringent needle-shaped MSU crystals as seen from synovial fluid from a patient with chronic tophaceous gout. We must acknowledge, however, that polarizing microscopy is not readily available and few centers have it. The next way we can diagnose gout is via imaging studies. On hand and feet x-rays, we will appreciate marginal erosions with sclerotic margins, often referred to as rat bite or mouse bite lesions. However, these lesions happen late in the disease course and has little value early on. Deposition of monosodium urate crystals on the chondrosynovial junction produces the double contour sign on musculoskeletal ultrasound. However, there are very few physicians trained performing musculoskeletal ultrasound in the country. The double contour sign is quite specific for gout and can be seen even before the onset of arthritis. Dual energy CT has yet to reach the country, but it's able to produce images that demonstrate urate deposition appearing as green structures surrounding the joints. Those from calcium deposits would appear violet on dual energy CT. What most of us will probably do is rely on clinical features in order for us to diagnose gout. If you go over the list, the joint involvement, the time course, the characteristic features echo those found in the gout classification criteria. The inclusion of male gender, associated cardiovascular diseases, and hyperuricemia completes the clinical features that will help us make a diagnosis of gout. It is important to emphasize that in a patient with joint pains, the presence of hyperuricemia alone is not sufficient to make a diagnosis of gout, particularly in the Philippines where a quarter of the population have elevated serum uric acid levels. Apart from diagnosing, the EULAR recommends screening patients for risk factors for hyperuricemia and associated comorbid diseases, as these subsequently impact on disease management. Following diagnosis, it is important to identify the stage of gout our patient is in. The stage will determine the treatment goals, which affects the pharmacologic and non-pharmacologic interventions we will use. During asymptomatic hyperuricemia, we would want to prevent the patient from ever having gouty arthritis. While during a flare, early termination of the attack is key. When the patient is in between attacks or has chronic gout already, the goal is to prevent flare recurrence, address organ damage, prevent morbidity, and reduce disability. Recent papers have suggested that at a certain point during asymptomatic hyperuricemia, crystal deposition is already evident at the joints. This stage of asymptomatic crystal deposition is of recent interest as this has been identified as a potential window for intervention. Among Filipinos, Dr. Di Chauco and group were able to demonstrate crystal deposition via double contour sign on musculoskeletal ultrasound among those with asymptomatic hyperuricemia at a level of more than 8.8 milligrams per deciliter. For the treatment of gout, we will refer to recent international and regional guidelines. The UPLAR guidelines have several Filipino rheumatologists as authors, including Dr. Lorenzo, our moderator, and Dr. Salido, our PGH division chief. For treating acute gout, all three guidelines recommend colchicine, steroids, and non-steroidal anti-inflammatory drugs as first-line therapy. There is no preference for any single drug. Interleukin-1 inhibitors were recommended as second-line therapy. Obviously missing in the guidelines are the use of intra-articular steroids and combination treatments which were highlighted of the 2012 gout guidelines. The decision on what to give depends on safety concerns, profiling our patients' comorbid diseases against the potential adverse events of the drugs we are giving. Other factors we should consider are the patient's prior experience, treatment, and any preference they have. Is there a hierarchy of treatment for gout? Colchicine, when given within 12 hours of flare onset, has comparable efficacy as oral steroids and NSAIDs in reducing pain, joint tenderness, joint swelling, and improving patient global assessment. Among the NSAIDs, acetic acid derivatives like indomethacin and diclofenac appear to be better in reducing pain when compared to propionic acid derivatives like naproxen and ibuprofen. Better than all these are the interleukin-1 inhibitors, canakinumab and rilonacept, both of which are not accessible in the country. Fortunately, better than rilonacept, but not as good as canakinumab, are the steroids given via intravenous or intramuscular route. This may be an important option for admitted patients or for those consulting at the ER or ambulatory care unit. Surprisingly, a study combining anakinra, an interleukin-1 receptor antagonist, with acetic acid NSAIDs showed comparable results as other single-agent interventions. An often missed opportunity with managing acute gout is the identification of triggers of the attack. Risk factors have been identified to trigger gout flares for unknown or various mechanisms, like air pollution, climate change, physiologic stress, joint injury, and dehydration. Factors that increase serum urate levels like medications, lead, intake of a high purine diet, alcohol, and decreasing renal function should also be sought. We should also recognize that drugs that lower uric acid levels may likewise trigger a flare. One worry we have when we admit gout patients for other conditions or procedures is the risk of developing an in-hospital flare. Stresses of concurrent illness and admission may trigger the gout attack. The Gout 36 rule was developed in New Zealand and externally validated in China and Thailand to predict the risk of developing in-hospital flares. We look at four conditions: whether the patient had no gout prophylaxis or urate-lowering therapy prior to admission, if tophi are present, and if uric acid levels are more than 36 millimole, 0.36 millimole in the year prior to admission. Each factor scores 1. If none of these are present, the risk of in-hospital flares are quite low. However, if most or all of these are present, the risk is high, reaching 80%. Unfortunately, since this was recently developed, we have yet to identify interventions that may lower the risk. We may consider prophylaxis similar to what we give when starting rate-lowering treatments. Among the agents, colchicine and NSAIDs are common across all three guidelines. However, it is only the American College of Rheumatology that recommends steroids in low doses as a prophylactic agent when there are contraindications to colchicine and NSAID use. A short duration of prophylaxis of 3 months may be given for patients with uncomplicated gout. But for those with tophi and nephrolithiasis, a longer duration of 6 months should be followed. Both international guidelines have identified multiple indications for starting ULT. So we should be thankful for the APLAR for distilling the evidence and reducing the indications to just 2. Urate levels of more than 9 mg per DL in the presence of tophi. Starting rate lowering during a flare is always worrisome because of the possibility of mobilization flares. While the recent guidelines did not make recommendations for or against the starting of ULT during a flare, the EULAR gave it a conditional recommendation. This is supported by several small, recent randomized controlled trials, showing that as long as we're adequately treating the flare with anti-inflammatories and have started giving prophylactic agents, we can start ULT during a flare without worries of extending or worsening the attack. Allopurinol and febuxostat are mainstays of gout treatment. Allopurinol is the first-line treatment for the ACR and EULAR, while febuxostat is second line for both. The ACR does remind us of the black box warning placed by the FDA on febuxostat by advising us to shift to other urate-lowering treatments should a patient have prior or new onset of cardiovascular diseases. Uricosurics as monotherapy or as an add-on to xanthine oxidase inhibitors were recommended for those patients whose urate levels remain elevated. For the APLAR, only bezinorad as an add-on to xanthine oxidase inhibitors was recommended for refractory gout. The perennial question of which is better between allopurinol or febuxostat needs to be addressed. Both drugs should be started at low doses, then titrated up gradually, with lower doses being used in patients with significant renal impairment. Convenience is the advantage of febuxostat, while experience is what allopurinol offers. Each drug has its own challenge. Allopurinol hypersensitivity syndrome and severe cutaneous adverse reactions are major concerns when starting allopurinol. That's why HLA-B 5801 is recommended to be tested among Han Chinese, Thai, Korean, and African American in the hope of reducing the risk of developing AHS. Febusustat has to deal with the FDA black box warning concerning adverse cardiovascular outcomes. But more than the drug, what is important in gout management is the treat to target strategy. Regardless of what urate lowering agent we use, achieving serum urate levels of less than 6 milligrams per deciliter is important. Earlier guidelines set a different target for patients with tophi, frequent flares, and those with gouty arthropathy. But why did recent guidelines not carry this over? Is there a benefit for intensive lowering of serum uric acid levels? The first guidelines actually recommended a lower target because there is faster dissolution of tophus. But recent papers suggest that 2 years after starting intensive versus usual urate lowering, there was no difference in the amount of erosions, frequency of flares, number of tophi, and the quality of life of patients. Instead, those who were on the intensive therapy arm of the study tended to have more combination treatments, and yet they still fell short of achieving target uric acid levels. The management of asymptomatic hyperuricemia is where controversy still remains. Hyperuricemia has been identified as an independent risk factor for worse outcomes in multiple diseases, such as chronic kidney disease, metabolic syndrome, type 2 diabetes, and cardiovascular diseases. In fact, hypertension has been found to be more refractory in patients with asymptomatic hyperuricemia, and coronary artery disease tends to be more severe among patients with asymptomatic crystal deposition. However, epidemiologic studies have failed to demonstrate whether the association of hyperuricemia with these diseases is that of causality, reverse causality, or as a result of a common causal factor. And going back to the association of hyperuricemia with gout, we'd have to treat 24 patients with asymptomatic hyperuricemia for 3 years just to prevent one of them from having his first attack of gout. So it is but reasonable that the guidelines continue to recommend that we do not treat asymptomatic hyperuricemia. Looking back at the associated comorbid conditions, we should look at treatments that mutually benefit gout and the comorbidities. For hypertension and heart failure, we should shy away from using thiazide diuretics and consider other options. There is preference for giving losartan due to its modest uricosuric effect, something that is not a class effect with ACE inhibitors and other ARBs. In patients with cardiovascular disease, we should not stop or shift aspirin if there are strong indications for its use. Among patients with dyslipidemia, shifting to fenofibrate is no longer recommended just to lower urate levels. Other things found in literature that may help in our decisions to treat comorbid conditions include the following. Amlodipine may be preferred when the hyperuricemia is secondary to cyclosporine use. There is preference for atorvastatin over other statins due to its uricosuric effect. And recently, there is interest in giving SGLT2 inhibitors in diabetics because it helps lower serum uric acid levels. No discussion of gout would be complete without mentioning diet. Nielsen reviewed 17 guidelines and identified common diet and lifestyle modification advice. We should limit the intake of beer and spirits. Red wine is still allowed in amounts supporting cardiovascular health. We should advise weight loss in overweight and obese patients. We should reduce our intake of sugar-sweetened beverages. We should learn to read the labels, and if either fructose or corn syrup are among the ingredients, we should minimize their intake. Purines from animal red meats, animal organs, seafoods, and fish should be limited to 1 to 2 servings per week. No restrictions were placed on fruits and vegetables. We should also try to incorporate low-fat dairy products if we are not lactose intolerant. It is important to point out that diet alone is responsible for only 3.3% of the variance in serum urate levels. And even if a patient was able to comply with previous and no longer recommended low purine diet, the most we can achieve with dietary modification is a 1 milligram per DL drop in serum uric acid levels. Now let's return to the bummer that I gave at the start of this lecture. Is gout care really suboptimal? Chong Nomson reviewed the global patterns of gout treatment from 67 papers. These were mostly from developed countries in North America and Europe, with few studies coming from Asia. Unfortunately, none from the Philippines. More than 6 million patients were included in the systematic review. Of the 6 million patients, only 52% ever received urate lowering. But if we look at the number who continuously and uninterruptedly receive the drug, the number goes down to 26%. Of the 52% who received urate lowering therapy, only 44% had their urate levels monitored. And among those, again, who received ULT, those who were able to achieve the target was low at 34%. This is just 17% of the 6 million patients with gout. This is a very dismal statistic. But both physicians and patients contribute to the problem. The healthcare system burdens physicians with the number of patients being seen per day, limiting the discussions we have with patients about their illnesses. There is also a focus on adult acute care, leading to patients only receiving treatment if they have symptoms. And many patients still underappreciate the role of urate lowering in gout. Some are not able to start it, and most do not even optimize its dose. For patients, they bring to the table multiple misconceptions. Reading through this list, we may be surprised on how some of these themes resonate with our Filipino gout patients, despite this paper being from a Western country. Something that we physicians probably are not able to identify is the stereotype associated with gout. Google gout patient and images of overweight alcoholics would appear. This would make patients blame themselves for having gout and lead them to a path of diet and lifestyle changes to the exclusion of medical management. Is there a way to address these problems? The recent guidelines suggest calling in other allied healthcare professionals to help improve the outcomes of gout. Doherty and colleagues compared nurse-led care with that of usual practice. What the nurses did differently were that they were able to discuss patient perceptions about their illness and correct any misconceptions. They also provided one-on-one discussions on disease association, consequences, and options to empower patients to participate in decision-making. This led to much better outcomes. 96% of patients were still on ULT after 2 years. 95% achieved target urate levels, and fewer patients had tophi and frequent flares. A similar study was conducted among clinical pharmacists in the virtual setting, where they were allowed to make adjustments to treatment based on monitoring lab parameters. Similarly, outcomes were better with other allied health professionals actively participating in gout care. So maybe it's time for us to call in the nurses and clinical pharmacists. So over the last couple of minutes, we were able to appreciate that gout is a metabolic and autoinflammatory disease, and its prevalence is increasing. Diagnosis can be done via clinical features, imaging, and crystal identification. Treatment goals for gout depend on the stage of illness. Interventions vary and include pharmacologic, diet, and lifestyle changes. A treat-to-target strategy is central to managing gout. We have to achieve serum urate levels of less than 6 milligrams per deciliter through pharmacologic and non-pharmacologic interventions. The partnerships in gout should not be limited to the patient and physician. It should also include allied health professionals in order for us to improve the outcomes in gout care. Thank you for taking the time to listen to my discussion.
si Ryan, na-diagnose po akong may gout arthritis ng 21 pa lang po ako. Nung una po, tuwing malamig lang po sumasakit, tsaka kung bata po, umiinom lang ako ng mga pain reliever, kaya nakakaya-kaya pa po kung malakas yung katawan. Pero nung mag-30 na po ako, doon na po ako nanghihina. Yung isang katrabaho po na ko, pinapainom ako ng steroid.
Kasi Berto Ramos, ang sakit ko po sa gout. Pag sumasakit po, hindi po ako makapagtrabaho dahil sa sobrang sakit. Pero nung ako po nagpagamot dito, sa awa po ng Diyos, hanggang ngayon, hindi na po nasakit.
Kasi dito balingkit, na may sakit na gout, namamaga ang paa. Pag namamaga yung mga paa ko, kamay ko, hindi ako nakakapagtrabaho kasi may sakit po.
Ako po ay hindi nakakatulong at hindi po nakakapagtrabaho dahil po sa sakit. Ako po ay nakukuha ko po sa aking trabaho sa kumpanya.
Sa pagkain kasi hindi rin ako makaiwas gawa na yun lang yung kaya ng budget. Tapos hanggang sa ito, papacheck up ako. Awa ng Diyos. Dahil sa gagaling ng mga doktor natin sa Pilipinas na ano naman ako na unti-unti ako nag-i-improve. Dati hindi ko mataas ng mga kamay ko. Ayun, pwede ko siguro pag-imbag. Hindi nga lang yung kamay.
Good morning, everyone. I am Tamondong-Lachica, and I'm here to discuss some strategies in improving and moving the needle towards better care in gout management. I'd like to thank the organizers of the LMLR 2023 for inviting me here. I also have no disclosures, and this is the outline for my talk. I'll start with gaps in gout care. Then I'll proceed to laying down the goals of gout treatment and then offer some strategies to improve gout management. So what are the gaps in gout care? And this is something that Dr. Sidney also mentioned earlier. But there are also gaps in diagnosis, and one of which is misdiagnosis. Some of our patients come in with gout, but they're confused with other rheumatologic conditions. That might be partially explained by synovial fluid analysis being underutilized, partly because some of our primary care physicians who will most likely see these patients firsthand, some of them do not recognize that there's a need for synovial fluid analysis. This is from a local study done here. And I think Dr. Sidney also mentioned that there's really lack of facilities or your microscopy to do the crystal analysis. Some of the, or majority actually also of those that were included in this local survey did not recognize that maybe multiple synovial fluid analysis may also be needed for some patients, and that will contribute to misdiagnosis. Another problem in diagnosis is delayed diagnosis, and this is something that more probably needs to be taken care of. This is partially related also to misdiagnosis. Some patients are being treated not for gout, even if they did consult for symptoms related to gout. In a local study, again, there was a mean of 6 years and even a median of 9 years from their symptom onset up to the time that they consulted and eventually being diagnosed with gout. And that might be partially explained by poor health-seeking behavior from our patients. This was also pointed out earlier that there's really suboptimal gout-specific treatment. And this is a combination of local and international studies where only about 30 to 75% of patients are actually prescribed urate lowering treatments, and many of them, as much as half or even 3/4 of them, do not reach serum uric acid targets. So that's going to be a problem as far as reaching our goals for gout care is concerned. Not all patients are also given urate lowering therapy. Not when patients are given urate lowering therapy, not all are given prophylaxis. So some may have problems with paradoxical flares during initiation of ULT. And this is very unfortunate. Only about 16% are actually given medical education. Interestingly, I found a study on claims data in the US where, in comparison to other non-communicable diseases like hypertension, hypothyroidism, diabetes, gout actually has the worst rates in terms of adherence to medications among patients. So this is something that probably needs to be seen more closely and probably taken into more local context, hopefully with more studies here in the Philippines. There's also the problem of fragmented treatment. As we have known, gout coexists with other conditions like hypertension, CKD, diabetes, obesity, metabolic syndrome, and even cardiovascular diseases and risk of death. More comorbidities are correlated with more healthcare utilization use, which makes us assume probably that maybe our patients are going to be seen more for their gout problems, but that might not be the case. We know that lifestyle and dietary habits are also related to the remarkable increase in hyperuricemia and eventually gout, and therefore weight loss might reduce flare risk. So that realization needs to be really emphasized among our providers. Gout relies on patient-initiated contact, meaning most patients really would come to their primary care providers or to their rheumatologist with some symptoms. And with that, there might be the opportunity to actually see patients not in flare might not be optimized. And therefore, the other needs of patients with gout might not be addressed. So let's understand why there are gaps in the quality of gout care and what are the barriers as far as providers are concerned. And this is a qualitative study done, and they show that there are knowledge gaps between among treatment providers, and there are varying treatment approaches. So for example, some of the providers actually were treating gout only as an acute condition and did not realize that there needs to be long-term treatment. They did not recognize the need to reach target serum uric acid levels, which I think was emphasized earlier. And there's lack of awareness of available guidelines. Dr. Sidney actually presented 3 guidelines that might be used by our providers, but there's lack of awareness of these guidelines. There are differing views and perceptions about gout patients among our providers. Some actually assume that they're already adherent to their medications and their lifestyle change, and therefore do not bother with reinforcing advice. Or some of them would actually not recognize that their patients are actually adherent to the medications and lifestyle and not provide advice as far as sustaining their improvements are concerned. And there are system barriers. I think one of the major limitations that was pointed out here was the time constraints in clinical visits. So therefore, improving health education, in addition to pharmacological and non-pharmacological advice, would be very difficult in clinic visits. And there have been notes of problems as far as literacy is concerned and communication with patients are concerned. And providers sometimes feel frustrated about not being able to communicate effectively with their patients regarding gout care. What are some barriers as far as patients are concerned? For patients, they have very limited gout knowledge as far as the nature and complications of gout. Some of them would even not realize that there are available medications for gout. There are also different attitudes and experiences with taking medications. And I think this is something that's not just for gout, but for many of our non-communicable and chronic diseases, and that patients are very reluctant to start taking long-term medications and feel that they only need to take medications on a short-term basis up until the time that they feel better. There are also concerns about side effects, and the presence of paradoxical flares when initiating rate-lowering treatment definitely will affect their behaviors and attitudes towards ULT treatment. Unfortunately, some of the interactions of our patients with healthcare providers are not that optimal. So some actually perceive the information that they got from their healthcare providers to be insufficient. And that might be related to the second item there, where patients actually seek information online. The problem with that is that while they're actively seeking information, that information may not be verified, no, or accurate as far as current evidence is concerned. And lastly, there are practical barriers to long-term medication use. Definitely in our local setting, some patients cannot afford their medications. And as I've said, since gout is actually associated with other non-communicable diseases, their patients actually might be taking too many medications, and they have to prioritize which medications they would like to adhere to. There's also lack of support strategies which might help adherence, particularly among older patients, and that might be in the form of reminders and bill organizers. So now that we've understood that there are suboptimal care as far as diagnosing and treatment gout is concerned, we've also identified some of the barriers as far as the system, the providers, and patients are concerned. Let's go now to the goals of gout management. And this is something that is very clearly laid out in the APLAR 2021 guidelines, where the goal is really to treat and prevent acute gout flares, prevent organ damage by removing your deposits, the MSU deposits from the body, and by lowering serum uric acid levels, and gout management being holistic, which actually includes not just your rate-lowering medications, but including also appropriate lifestyle choices and adequate treatment of your comorbidities. That's on the provider side. However, there's a study now on what are goals for gout management according to our patients. And this list is actually arranged from most important to them to least important. So for them, it's most important to prevent and better manage their flare-ups and improve their function, eliminate flare-ups and provide disease remission, actually embarking on lifestyle change and having modifications in their diet and activity in itself is actually a goal for some of our patients. Patient education and more awareness on gout is also one of their goals. And lastly, and sometimes something that we might be not really emphasizing is medication management and minimizing side effects. So I think that it's important for us providers to make sure that our goals are aligned with the patients before moving forward with treatment, because only then can we actually make sure that moving forward we have clearly articulated goals and be able to reach those goals. So how can we move the needle towards better gout care? And I will provide some suggestions here. I think from the slide on the barriers earlier, we really see a lot of emphasis on education. There needs to be more concerted effort to provide more adequate education, not just for our patients, but actually for providers as well. So on the provider side, it will be useful to actually disseminate the guidelines more widely, particularly among primary care providers, who for some patients might be their nurse, their midwife, their pharmacists. No? So disseminating the guidelines more widely is actually important, because unless these guidelines are disseminated widely, they won't actually be used. In some chronic conditions like heart failure and diabetes in the United States, for example, their care is actually linked to performance-based incentives. So when physicians, for example, or providers are able to control their patients' HbA1c, for example, in diabetes, or if they're more able to prescribe beta blockers and ACE inhibitors or ARBs for their heart failure patients, which are the evidence-based interventions for heart failure and diabetes, respectively, then they're actually being given incentives. And I think this is something, the direction which might be something that we can explore here in the local setting, and that might push providers to knowing more about gout and treating gout better. Now, for the patients, One of the things that has been very helpful to me in my practice is setting what I call a patient education curriculum or plan. So for my patients with chronic conditions, I usually lay out a plan for how I educate my patients. Imagine if you were educate your patient about gout, talking them about the pathophysiology, the symptoms, the need for medications, the prognosis, in one sitting. It can be very overwhelming. And unfortunately, our patients will not really absorb anything that you'll say. So what I put in my chart is actually have a plan. So for example, in the first visit, maybe the priority for me is for them to understand why we need to treat the gout flare, and maybe why we need to have strict adherence to the medications. And maybe on the next visit, I'll try to emphasize what gout is, what are the complications of gout, and then maybe later, maybe some of the other facets of gout that we have not discussed in the previous visit. So something like that, so that patients actually have a focused curriculum in a way, as far as knowing what gout is. And this is something that I do for many of the chronic conditions that my patients have. Reinforce educational interventions over time. So we can use a lot of different strategies in educating our patients. So that might mean just talking to the patients and explaining. That can be in the form of a brochure. I think there are a lot of readily available patient education brochures. But now there are a lot of available online videos and resources that are available for our patients. And offer these to our patients and ask them what is the most effective for them, and maybe reinforce these interventions over time with the different items as far as your education about gout is concerned. And lastly, gout is a very complicated disease. Knowing the different prognostic issues and complications and management is actually very complex. So it helps to make sure that patients understand the principles. Maybe forgot it is the principle of having treatment not only for acute flares, but actually preventive treatment for those flares and preventive treatment for developing complications. This is important because if they don't know the principles, it might be hard to really anchor them in what your plan of action will be for gout. Now, I'm very much in awe of the APLAR 2021 guidelines, and Doc Sidney mentioned that some of the authors are really our mentors here in PGH. One of the things that they emphasized was patient decision aids in the shared decision making, and one of the things that can help us with shared decision making are patient decision aids. So this is an example that was done in Singapore, and it's very unique in the sense that this is particularly for gout, and this was developed not just by physicians but actually with patients. So the decision aid in itself was developed with patients. Now, what are decision aids? These are visual representations of the benefits and risk of treatment in the hope of supporting patients get to a decision about their care. So here, for example, we are educating our patients about gout, what it is, how do I know if I have gout, when do you need treatment, and then clearly asking the patient on what decision needs to be made. So your doctor thinks your gout needs further long-term treatment, and what would be some of the things that matters to you as far as deciding what treatment is concerned. Should it be effectiveness, side effects, or cost? And here you're already asking the patient for a final decision. This is a brochure that they might bring home to really mull over. And this is the second page where all of the treatment options are laid down for the patient, and putting there what the benefits, how effective the treatment is, and some of the side effects. And it even includes the possibility of not treating or not giving any pharmacologic treatment, so that they know what would be the benefits, or if there are, and side effects if they don't get into a pharmacologic treatment. So cost is very important for our patients, and that's represented there. And I think this is something, hopefully, that we can develop here locally. We've had some success with developing patient decision aids for diabetes and osteoporosis, and hopefully this is something that we can take on here in the Philippines in the local setting as well to help our patients. Now, It's very important in long-term management of diseases, not just for gout, but for many of our non-communicable diseases, that we improve patient engagement, which means that we improve our patients' ability to steer their decisions towards their better health. And how can we do that? There's some, these are some tips now using the 6 S's. So what are the 6 S's? So for example, the first S is be as specific as possible with instructions. So for our gout patients, don't just say stop drinking alcohol. No, patients will not know what to do. So what do? We deliver simple information in written or audio or video form, maybe give a YouTube video about what works and what might not work, and supply the how, not just saying the instruction. How do they actually stop drinking alcohol? Avoid use of jargons and use your decision aids, and that's in the vein of keeping your information simple. So that's the second S. Don't use jargons and use visual aids. Next, get patients involved in setting their goals. And this was something that we talked about earlier about having shared goals with our patients. And it might make sense to that when you set goals with your patients, aim for small hills, not mountains. For example, if you're talking about lifestyle interventions for gout, maybe the first goal is to just eliminate your beers and spirits. Maybe the next goal is actually eliminating the other disease or eating more healthily as far as your meat consumption, etc. is concerned. So it helps for patients to actually have smaller goals in their attempt to reach the bigger goals, and congratulate them on their small successes so they feel empowered and they feel that they're moving towards their end goal. Make information shareable, and this has been a recent change in the treatment of chronic diseases, and that we develop a longitudinal plan of care for our patients. Rather than working in isolation, we clinicians should work across different settings. And how can we make sure that our information is shared? We use our electronic health record. This is the ideal setting for sharing plans, support information, and whatever else is needed, so that our patients are actually receiving consistent direction and encouragement from all members of the team. So the physician is saying the same thing, the pharmacist is saying the same thing, the nurse is saying the same thing. So making everything accessible helps this. Ensure everyone is on the same page. So probe to ensure that what you're saying, let's say X, is actually being heard as X and not Y by the patient. Otherwise, they may end up adhering to a plan that's nothing that like you intended. So for example, healthy eating for you might mean fruits and vegetables, but for your patient, it might mean vitamin supplements. So you have to make sure that you're on the same page. And lastly is set accountability. That's the last S. Helping patients track progress towards goals, either individually or as part of a group of like-minded or like-minded patients, can be extremely valuable in driving engagement. So keeping tangible reminders about these goals will come in handy and will help, especially if our patients begin to waver in their plans. And I think this was something that was emphasized also earlier by Doc Sidney. Usually all hands on deck in terms of gout care, and we need to put in team-based care there. And the team approach leverages on each member's strengths. It actually has been proven across many disease settings to have fewer errors and protects the healthcare members of the team from work stress, because the load is actually shared. One of the examples of this is a pilot multidisciplinary gout program in the US, where patients were given nurse-taught curriculum. The doctor's the one that sets the prescriptions and the frequency of testing. And then the pharmacists do monthly calls to monitor adherence to the treatment plan and answer questions about possible side effects. So everyone is doing their share, and all of the needs of the patients are addressed. And I think this was also something that Doc Sidney mentioned earlier. The nursing-led and pharmacy-led gout management programs have been successful in getting patients to their serum uric acid goals. And interestingly, in these nursing and pharmacy-led gout management programs, patients reported a sense of autonomy, power, and security. So I think these are things that we might be able to explore in the local setting as well. So we should leverage on technology. I mean, most of us actually spend at least 2 hours in our gadgets. So let's leverage on our use of technologies and include that, in our strategies to promote patient empowerment, to deliver our health education there. And one of the things that I'd like to share here is actually I searched for apps that help with gout management. Probably one of my favorites is Gout Central from the National Kidney Foundation. It's a free app. Not only does it help patients with putting in their the diet that needs to be done for them and their lifestyle change, but it also has educational prompts on what gout is, what are the medications, etc. But these are the other apps like Oxypore, Purity, Gout Choose This, Not That, and Gout Mecazo Medical. And there are, as far as medication adherence is concerned, there are a lot of medication reminder apps out there that maybe would help patients be more adherent to their medications. So I think what I would like to end with is that we should have shared responsibility with our patients, putting both our accountabilities to each other, as the provider and the public, acknowledging that we are both autonomous, but definitely can share a common goal. And with that common goal is something that needs to be articulated and monitored throughout. And this will be helpful, not just in gout, but in many chronic diseases. And with that, I'm offering my email address for any questions our audience might have. Thank you very much again for having me.
Thank you very much, Dr. Manahan and Dr. Lachica, for your excellent talks on gout and how we can improve the management of it. We have some questions in the Q&A box, and let us proceed with answering them. So this is a question from Dr. Angelica Canu. What level do we treat asymptomatic hyperuricemia? So maybe Dr. Manahan can answer this.
Yes, sir. Thank you for the question. Asymptomatic hyperuricemia, the recent papers do not actually recommend a level at which we should treat asymptomatic hyperuricemia. When we do detect this in our patients, we should try to implement diet and lifestyle modifications to help lower the serum uric acid levels. Apart from these, we have to evaluate what are the possible causes of the elevated uric acid levels. Is it because you are overweight? Are you taking too much alcoholic beverages, sodas, sugar-sweetened beverages? The works. We have to determine what is the cause of the elevated serum uric acid levels. And if after evaluation, and we have addressed the other risk factors, maybe we can discuss treatment if your uric acid levels are still more than 9 milligram per TL. But from previous papers, a level of 11 for females and 13 for males would be reason enough to treat asymptomatic hyperuricemia.
Thank you, Dr. Manahan. Dr. Diana, you have any comment on this question? At what level?
No, sir. I think Doc Sidney answered it adequately. Thank you, sir.
Okay, thank you. This is always an issue. And I'm going to bring up diet. So what are your thoughts about tart cherry supplements for gout? Now, this we can expand to any dietary issue with gout. So maybe you can answer this, either Diana or Dr. Sidney.
Yes, sir. Diet is indeed of much interest to any patient because gout is one of the conditions in which diet plays a big factor in development. Well, as for cherries, there are actually some evidence suggesting that vitamin C may help reduce serum uric acid levels. So vitamin C is present in some fruits, particularly citrus fruits. But as far as cherries, there are indeed small papers suggesting that it may also help improve control of our hyperuricemia. But then again, the problem with diet is you have to be consistent, like every day, for it to have a significant impact on your uric acid levels. That's why, personally, in practice, I mention the diet and lifestyle modification, but I always reassure the patient that if you, for example, skip out on the diet and lifestyle changes for a couple of days, they don't have to worry because there's always pharmacologic treatment. So I think if we are able to effectively use our medicines, we need not worry too much about the diet as long as we are open about discussing what are the problems we have about dietary changes.
Thank you very much, Sidney. And Diana, any comment on this?
Yes, sir. I actually did a very quick search and there's a meta-analysis on cherry supplements now. I will have yet to appraise this, but it seems like from this meta-analysis that they might be correlated now with reducing serum uric acid levels. However, the problem with the studies is that they're not, the cherry supplements are not uniform. They are probably not regulated, and the methodologies are not quite good. So I think even with the result of just having serum uric acid levels, the fact that the studies are not of good quality might make us, shy away from really routinely giving this for our patients. And just a quick caveat about diet, I think definitely as Doc Sidney mentioned, no, that there is a role for gout management in terms of diet, but the diet modification that we'd like to advocate for our patients not only should just target gout. I mean, many of our patients really have other comorbid conditions. So the diet advocacy there should go beyond gout. So improving their other comorbidities and overall health.
Thank you very much. And I just want to add to this that, diet is only part of the treatment. It's not the entire treatment. So you might have patients who say, I want to follow a very strict diet and that's all I want to do. And that does not work. We know that does not work. As Sidney has mentioned, medications are very, very important in the treatment and management of gout. So thank you. We go on to the next question. Why does aspirin worsen a gout flare? And then what medications raise uric acid levels? I think Sidney also mentioned something about medications and
Yes, sir.
triggering hyperuricemia.
Yes, sir. For the first question about aspirin, low doses of aspirin will impact how our kidneys handle serum urate filtered through it. So low doses may actually inhibit the excretion of urate and lead to hyperuricemia. This is in contrast to high doses of aspirin, which do not usually affect urate handling by the kidney. So when we say high doses, around 3 to 4 grams of aspirin, or that's if you're using the 80 milligram aspirin, that's around 30 tablets per day. So we don't use that anymore. About medications, most of the medications that increase uric acid levels, apart from aspirin, include our thiazide diuretics. Many of our hypertension medications come as combination pills, and thiazides are part of that combination. There are also TB medications. Your pyrazinamide and ethambutol are notorious for increasing serum uric acid levels, and cyclosporin, which is used in transplant and some rheumatic disease, may also increase serum uric acid levels.
Thank you. Diana, any contribution to this?
No, sir, okay na.
Okay na. All right, so we go to the next question. Is there a chance to have heart failure, I presume, during a gout flare-up, or if a gout flare-up will trigger heart failure? I'm not sure how this question is, what the exact meaning of this question is, but you might want to answer it. And what is the management of gout, I presume, during heart failure, acute flare-up?
heart failure, the treatment may actually trigger an attack of gout because if you think of a patient with heart failure, part of the management is the use of low-dose aspirin and your diuretics, which are mainstays, particularly if your patient has congested lungs, not putting out enough fluid, then we have to decongest the patient by giving diuretics. And the diuretics and aspirins may do the patient in and trigger an attack of gout. Now, as for treatment, it will really depend on how bad the gout attack is. If you're talking about one joint, one large joint like the knees, we can actually do intra-articular steroids injection to help relieve uh, the arthritis attack. The problem with heart failure is some of the medications we use for treating acute gout may cause problems in heart failure. For example, your NSAIDs, your ibuprofen, naproxen, diclofenac, they may actually worsen the heart failure. So we tend to shy away from this medication. Even systemic steroids, when taken, this can also worsen the heart failure by leading to volume retention. So the only drug we can safely give orally is colchicine. But then, as I mentioned, it should be administered within the first 12 hours of an attack because beyond that, it will be of minimal benefit. So if, for example, you have one joint swollen, we can inject the joint, put steroids in, the patient can be happy without worrying about his gout while recovering from heart failure.
Thank you, Sidney. So for the next question from Dr. Ferdinand Alcos, and I think this is really important. I'm curious to see what your answer is. How can gout management be tailored to meet the unique needs of pregnant or breastfeeding individuals, taking into consideration the limitations and potential risks associated with certain medications during pregnancy and lactation?
Okay.
Either Diana or Sidney can answer. Thank you.
Yeah,
Parang this
you
is for
want?
the specialists.
Okay. Okay. First off, let's start by saying that gout does not usually happen in young females. Gout in females typically happens after menopause, or if you're elderly and taking thiazide diuretics or antihypertensives to control your hypertension. So we don't really expect gout to happen in young reproductive age females. But for the off chance that you are a young female with other comorbid conditions like a heart problem, and then you get pregnant and you develop gout, then we would have to form a team with your cardiologist to discuss what is best. Not only your cardiologist, but also your obstetrician to discuss what treatment will be best for you. If you are having a gout, an acute gout attack, probably we can try steroids because some forms of steroids do not close the placenta, so it will not affect the fetus. As for allopurinol and pibusostat, we have to review the data there because as far as I recall, not much studies have been done on pregnancy and allopurinol, but I have to check that with about that again.
Thank you, Sidney. So there are many, many questions, and actually, I want to jump all the way to the end because maybe Diana can answer this. It was mentioned during the slides of both speakers that nurses were trained on gout care. Is there formal training on it? If have, how to participate?
Yes, sir. I think this was something that actually asked our colleagues from the College of Nursing if there's a specific like treatment for gout care among nurses, and I think there's none, and they mentioned that there's none. But in the programs that we cited, the programs that I cited in the lecture, there are the nurses that are actually there in the programs are nurse educators. So those are the nurses who have particular specialty or expertise in educating patients. So that's where there's also even one particular study where it's the nurse educator that they actually evaluated in terms of effectiveness in delivering gout-related information. So as far as gout-specific training, I don't think so, but the nurse educators are the ones that are really involved in the gout programs that we saw.
Thank you, Diana. So we move on. Plenty questions. Do we have special considerations for asthmatic patients with gout taking NSAIDs?
Yes, we have, because we have to understand that some form of asthma may actually be sensitive to NSAIDs. That's why we have to identify if your asthma is the one that would adversely respond to NSAIDs. In such case, probably I will give steroids rather than NSAIDs for the treatment of acute gout. Colchicine, we don't have to worry about it because it does not have an impact on your asthma.
Thank you. Can colchicine be used as a maintenance for gout?
Well, as mentioned, colchicine is not maintenance because it does not impact on uric acid levels. So if you read colchicine, its role is actually to help reduce the chances of flare or attacks of gout while your uric acid level is still high. So as mentioned, the newer guidelines suggest 3 to 6 months of colchicine, after which we can actually discontinue the colchicine. And the real maintenance medications in gout are your febuxostat or allopurinol.
Thank you, Sidney. I'd like to ask Diana. It's really the whole point in the management of gout is really for me the target serum uric acid level, which is below 6.8 milligram per deciliter. But you mentioned that often it's really the problem is really patient adherence, okay, and then we have issues with fragmented treatment. So how do you suggest we actually address these problems? You may have mentioned it, but I think this is so important because we all know what we want. We have very good medications to treat it, to cure it, and still we're not having the outcomes that we need. We still have patients with, as we saw with tophaceous gout in the videos. So how then do we improve our adherence or what you call it, when they want for maintenance issues of the medicines? How can we help our patients? Thank you.
Thank you, sir. One of the things that in my conversations with my patients, one of the things that I found out is that they deprioritize their medications, meaning they actually are the ones prioritizing their medications by themselves. So one of the things that they consider when they do this is that what are the things that are most tangible to me? What are the drugs whose effects are most tangible to me? So for example, some of the patients really have, I think for gout, for example, they will prioritize the pain medications, the things that will actually alleviate their pain, improve their function, rather than, let's say, allopurinol or your febuxostat, because this is something that's not tangible to them. They can't actually see what the results are. So one of the things I really make sure of is whenever I discuss the treatments, particularly the medications, is to actually articulate verbally and also write it down for them that this is something, okay, this is for lowering your serum uric acid level. Why do we need to lower it? Because like this and this. And this is for pain. I think once they understand that you're offering them something for the long haul, something that will prevent them from coming into the office or coming into the ER with pain, they're much more likely to be more adherent. And I found also, while there are a lot of patients who are older, and I think not naman just old, but having to take medications on a daily basis is really a problem. It's really a hassle. So I've been having success with the apps that yung mga medication reminders, because they have an alarm for when they will come up. And I try as much as possible to design their medication plan to be more or to be less complicated. So if we can have by the less frequent dosing, I would offer that. Or if there's some things that I have like office people who go to the office who might not be able to do it in the morning, maybe take it at night. So yung mga things, small things like that might make a big difference for our patients to improve their adherence. So it takes some time because it will take some conversation. And I have readily available na parang list na of apps for them to try out. Mostly free naman po.
Thank you. So that's very, very important information, and really how much patient education plays a role in our management. We often take this for granted. We only have, let's say, 10 minutes to talk to our patient, and that's it. And if they don't understand, then we lose them, basically. We lose the opportunity to actually manage them properly. And so maybe spend a little bit more time, or have a system or a process wherein, as you do, to have, what was it, some patient education curriculum uh, attached to all to all your gout patients, so that once they see you see them in the clinic, this automatically is adhered to. So thank you, that's very, very important. Okay, so we move on. For anonymous attendee, for trans patients on HRT, the, for, I think things got lost here. I think it was an issue is there an effect on the uric acid levels, and do we follow the uric acid levels based on the male or the female? So can anyone answer this?
Yeah.
I cannot find the question
I was
anymore.
able to answer it, sir, in the
Okay.
chat. So the question was among trans patients on hormone replacement therapy. If they have elevated uric acid levels, which sex do we follow? Is it the male or female sex? So this is actually a gray zone in terms of management, because issues about transgender health, LGBTQ issues are just emerging now, and we haven't adequately addressed or identified all the gaps in our medical knowledge about this. But personally, we can look at the physiologic standpoint. But realistically speaking, if you are on HRT can actually help lower serum uric acid level. That's why young females don't have gout because of their hormones. But if you're on HRT, probably I will follow the female cutoff of 11 milligrams per DL.
Okay, thank you. So good morning, doctors, from an anonymous attendee. In terms of colchicine as part of the acute flare control regimen, what can be a possible alternative in case the patient manifests with adverse effects like chest heaviness or diarrhea? Should this entail further investigation for presence of comorbidities? Thank you.
So I'll answer this. Colchicine is notorious for causing arrhythmias and diarrhea if taken at very high doses. That's why if we read recent guidelines, we no longer follow that 2 tablets now, then 1 tablet every hour until you poop or experience some adverse effects. Right now, if you look at the recommendation, it's only 2 tablets now, then 1 tablet after 1 hour. So that's 3 tablets per day. So if you experience adverse effects like diarrhea, well, if you took too many colchicine, that is an adverse effect, and that would suggest colchicine toxicity, and we would have to not give colchicine for the next 2 weeks so as not to aggravate the toxicity. In terms of your chest heaviness, I would seek cardio consult. Maybe we have to evaluate, was the chest pain associated with arrhythmia, because if it was, it may still be an adverse effect associated with colchicine. And in that case, we would still follow the protocols regarding colchicine toxicity, which is we have to hydrate. Some authors would suggest alkalization to promote excretion, and avoid giving colchicine for the next 2 weeks for the excess colchicine to be washed off from our body. We have to remember that colchicine is non-dialysable, so referring to nephro may not be that helpful. So we just really have to manage the adverse events as they come in.
Thank you, Sidney. Next question, nakaka-trigger po ba na magkaroon ng gout ang patient diagnosed with cancer? And I think Dr. Hazel Reyes, our rheumatologist, also is going to answer this question. Dr. Reyes, are you there? Oh, so it's not so anyway, I'll pass this back to Sidney, Dr. Sidney.
Yeah. Well, we have to look at what type of cancer we are dealing with. Most hematologic and lymphoproliferative cancers are characterized by high cell turnover. If this is the type of cancer we are dealing with, it can actually increase serum uric acid levels. Likewise, for other solid tumors, some forms of treatment may actually precipitate what we call tumor lysis syndrome. And part of this syndrome is elevation of your serum uric acid levels. That's why if you're a cancer patient ongoing chemotherapy, your oncologist most likely will hydrate you and probably take baseline measurements of your uric acid levels and start allopurinol even in the absence of any symptoms.
Thank you, Sidney. I think we have maybe two more questions. What treatment for patient with uncontrolled gout in spite of allopurinol, febuxostat, etc., still with gout flares?
Okay, so then it's okay if I answer this.
Yes, sir.
Okay, so first we'd have to look if you already satisfy criteria for refractory gout. So refractory gout is one of those bad forms of gout where even after optimizing your treatment, you still continue to experience attacks, your uric acid levels continue to be high, and your tophi continue to increase. However, based on a recent study, we have to evaluate whether you are actually optimized on your rate-lowering treatments. Many Filipino physicians are afraid of raising allopurinol beyond 300 milligrams because if you check your MIBs or any medication reference, most of them will cite that the maximum dose of allopurinol is 300. But if you go to the US, it can go up as high as 800 milligrams. In the European countries, as high as 900 milligrams. So we really look at your dose of rate-lowering therapy, whether you're optimizing it. We'll also look at your lifestyle, whether you're hydrating enough, you're avoiding colas and sugar-sweetened beverages, you're not smoking, your comorbid conditions are controlled, and if you are overweight or obese, we'll probably put you on a weight loss program.
Thank you, Sidney. So I'll just one more question before we end. Which is very fair. What causes gout to develop in some people with high uric acid levels, while others with similar levels do not? While others with similar levels do not experience any symptoms. So this is asymptomatic versus symptomatic gout, and they have the same uric acid levels.
Well, based on our understanding about the progression from asymptomatic hypersemia to gout, a lot of this has to deal with genetics. So some patients, they have elevations in uric acid because of lifestyle, because they're overweight, because of the diet that they have, or some comorbid conditions that they are trying to control. But for some patients, the transition from asymptomatic hypersemia to gouty arthritis is a factor of genetics. That's why if you remember earlier, I mentioned that diet will only account for 3.3% of your uric acid levels. The progression to gout is actually genetics in 24%. So that's 1/4 chance of developing gout based on genetics. So probably if you're comparing patients, I'll probably ask the family history. If there is a family history of gout in the first degree or second degree relative, you're most likely to develop gout at the same age. But the real reasons behind this, we still are trying to find this out, but certainly it's genetics, and the mechanisms for these are still poorly understood.
Thank you, Sidney. Okay, so I think we've reached the end of our webinar, the time allotted. And for the others with unanswered questions, we will try our best to answer these and send your answers on the chat, on the Q&A chat. So I'd like to thank Doctors Manahan and Dr. Lachica for your excellent and wonderful lectures. I really learned a lot, and your Q&A participation was also much appreciated. And I'm sure our audience also learned a lot from you today. Thank you to the audience for your interesting questions. And whenever the topic is gout, I've noticed that the questions just don't stop. And there are always new questions that surprise us every time. So this afternoon we learned a lot. We learned about the management of gout, what the guidelines say, what's up to date. We learned where the gaps are. Very importantly, why we should engage our patients, include patient education in our management. And of course, us as healthcare practitioners, we should also be up to date in our management. We know the cure. We just have to make sure that the cure actually reaches our gout patients. So we'd like to thank the Information Management Service Network team of the UP Manila and our sponsor, Sandoz Philippines. And thank you all for joining us as we end this webinar. We hope to see all of you on July 20 for the LMLR webinar on back pain. Have a great morning, everyone. Thank you, Dr. Lachica and Dr. Manahan. Thank you very much.